Dear colleagues, it's a great pleasure to introduce today's Zoom meeting about rectal resections. In which situations can we avoid diverting stomas, pros and cons? We decided in the International Colorectal Cancer Club to discuss this topic because it's becoming more and more common in many countries around the world that surgeons try to avoid diverting stomas in patients after rectal resections, not only due to infections, but also in situations with cancer. And it's a great pleasure for me to introduce as a first speaker Moritz Schwab from the University of Ulm. He started his career at the university in Cologne and then moved to Ulm, and he is now responsible in our department for the section colorectal surgery. And I will hand over that he can give his talk. Please, Moritz, start. Thank you very much.
Yeah, thank you, Marco. Dear Chairman, dear Mr. Ivanov, thank you for inviting me. It's a great honor to give a talk about rectal resections with or without a diverting stoma. So when I started my career, Marco told already in Ulm, it was common to have, can I click the next? Okay, it was common to have an open rectal resection with a Hartmann procedure in rectal cancer, and not often with a Hartmann reversal later on. So 16 years ago, but with minimally invasive surgery, the options have changed right now. It's more and more common to do the low anterior resection with an anastomosis, and now we're talking about with or without a diverting stoma. So let's start with LARs with diverting stomas, and which situation are we planning the procedure with a stoma. In our institution, we are planning protective diverting stoma right away with when we plan a very low intersphincteric stable door Hansoon anastomosis, and we plan the diverting stoma when the patient has previous pelvic radiation, for example, after prostate cancer therapy. So these are situations in which we definitely plan a diverting stoma. So intraoperatively, when the air leak test fails, so it's clear to divert with a stoma. And the old Hartmann resection, we only plan this procedure when sphincter infiltration is clear and there's no chance for preserving the sphincter. The LAR without diverting stoma, we always to achieve the situation. But first, we have to prepare our patients before we take them in the OR. And with preparation, I mean the bowel preparation combined with oral antibiotics. We always mark the stoma in case we need them. And we established in our institution the ERAS program with sometimes prehabilitation of the patients to get them in a better condition for the surgery. So to have a first sum up, the diverting stoma we only use when with very low anastomosis, very deep anastomosis, when we have a failed intraoperative leak test or previous pelvic radiation therapy, or we plan an extended tumor resection with other organs. So we have a bad condition of with the perfusion. The end colostomy only with sphincter infiltration. And our standard in our institution is or should be the LAR without diverting stoma. So I brought a case, let's say a normal LAR case with a tumor 10 centimeters from the AC line. So we planned a PME on a male, age 58, and an ASA 2 score. So the tumor was a small one. So we did an endoscopic tattooing before the procedure, and as always, we prepared with a bowel preparation and antibiotics before the procedure. So this is our standard minimally invasive approach with our Da Vinci Xi robot. And we normally do a medial to lateral approach to have a better preservation of the nerves. So in a second, you can see the tattooed tumor at the dorsal end of the rectum. So we did a low tie and preserved the left colic artery to have a better perfusion of the colon descendants. So the ligation of the superior rectal artery, you can see here, but we combine it with a lymph node dissection from the IMV. So intraoperatively, we check for good perfusion with an ICG and the Firefly mode. So here we see the perfusion of the colon right here. And we use the tri-staple technology with 3 stapler rows on each side to have a good closure later on. So another intraoperative tool is to prevent the dog ears phenomenon. So we do a lateral invagination technique, and with the stitches, we try to put the lateral ends together. So later on, the anastomosis doesn't have the so-called dog ears. Also, we use the tri-staple technology for the circular stapler. We normally do a side-to-end anastomosis. Also due to a better perfusion of the anastomosis. We always do an air leak test. So in this case, it was normal, no leakage. So there was no need for a diverting stoma. At the end of the procedure, we place a 16 Charrier Foley catheter transanally for tube decompression. We leave it there for 3 days and then remove it. Sometimes we place an endosponge for 5 days, then remove it and have the anastomosis checked via endoscopy. So postoperatively, the patient had until day 5 a normal postoperative outcome, but on postoperative day 4, he started to have low abdominal pain. The infection parameters started to rise, so we did a CT scan, but there were no air bubbles around and no abscess. So on the same day, we did an endoscopy and we saw an anastomosis leak right here. So what now? We didn't perform another operation, so let's say this, but we put into endoscopy again, and we're happy to have strong partners in our endoscopy department, so they are able to place an endovac, or in this case, a vac stent, to cover the anastomosis and the leak. So we combined it with IV antibiotics for 5 days. So the patient recovered. And so these are photos from the initial placement of the endovac, of the vac stent. And we checked the position of the vac stent with another CT scan. And still there were no bigger signs of an abscess. And after 7 days, we removed the vac stent and checked again the anastomosis, and we saw the practically complete healing of the defect. So what is the new standard? In our department, we always try to avoid a diverting stoma. I said later on, the problems with patients who had radiation therapy is still a problem. So we don't do an LER without a diverting stoma on these patients, but our standard procedure is without a diverting stoma. But it's very important to have a preparation of the patient with our initiated ERAS program and with sometimes prehabilitation of the patients. Another very important factor is, or are, the intraoperative tools we have. For example, the ICG we use for check of perfusion. So the stitch technique to prevent dark ears in the anastomosis, and also very important, the tube decompression with a Foley catheter. The postoperative surveillance is another big role in our treatment. So we check every 2 days for infection signs in the blood. And if we have signs of an infection, we have a very low level to put the patients in CT scan or perform a colonoscopy to check the anastomosis. And as I said, we are happy to have very strong endoscopic partners who can place a VAC stent or endovac to cover the anastomosis and treat an anastomosis leakage without another operation later on. So thank you. That's it. And I'm happy to answer your questions, and I'm excited for comments. Thank you.
Moritz, thank you very much for this clear talk about the way of management that we do here. Are there any comments on the floor? And I would also go to Andrei Ivanov, the secretary of the International Colorectal Cancer Club, who is going to take over the discussion now. Andrei, please go ahead.
Okay. Good morning, everyone. And be friendly and ask question. Boris wants and first speaker, please, maybe from China. And Dr. Schwab, what cases you strongly recommend to use protective stoma and not avoid?
Cases with a diverting stoma, as I said, it's very important to filter out any risk factors with healing of the anastomosis. So that's what I showed is often a previous radiation therapy, which involves the or alters the healing of the anastomosis. So that's a risk we don't take, and that's why we're planning a rectal resection with a stoma on these patients. But normal patients with a rectal cancer with no other risk factors, so that's, I say, the standard patient. So we plan to do the rectal resection without a stoma. So that's our standard in our institution.
I see. And maybe second question, do you use routinely colonoscopy intraoperative just after you done anastomosis or check the quality of anastomosis?
No, not routinely. So we only check after the after surgery when there are signs of infection or the patient has abdominal pain. Another situation is when we place a prophylactic endovac. So then we want to know, is there any difference in the area of the anastomosis? So when we place a prophylactic VAC over the anastomosis or inside the anastomosis, then we check after postoperative day 5 normally and have a colonoscopy again, but not routinely.
Yeah, I see. And maybe anyone wants to ask something? Many thanks for your introduction this topic and review. And we should move on. And next speaker from Russia, and Dr. Emil Churchill will present the trial. The the idea was trial was one of the leader of Russian colorectal surgery, Ilya Chernikovsky. Unfortunately, today he can't be with us. And Emil, please.
Dear colleagues, thank you for the opportunity to present our research project. First of all, I would like to introduce myself. My name is Emil Churchill. I'm a surgeon and oncologist in the Department of Colorectal Oncology at Moscow City Clinical Oncology Hospital number 62. I work under the supervision of Ilya Chernikovsky. The main topic of today's meeting will be rectal anastomosis without a diverting stoma, pros and cons. I will focus on why we decide to conduct the study at our hospital and what it entails. So, the formation of preventive stoma during low anterior resection is generally accepted standard, but are we sure we ain't missing something? The main reason for creating preventive stomas is that preventive stoma in the event of anastomotic leak reduce the severity of complication. This is supported, for example, by a study from our colleagues in India, which showed that using a preventive ileostomy in low anterior resection reduced the risk of the most severe postoperative complication and promotes faster recovery. However, this approach comes with its own set of problems related to stomach care and its complications. Results from another meta-analysis investigating the role of preventive ileostomy show that while a preventive ileostomy mitigates the consequences of a leak, it itself leads to numerous other complications. Patients with an ileostomy had a more than three times higher risk of other complications compared to patients without one. The study authors themselves state that higher quality RCT are needed before ileostomy can be recommended as a routine practice after rectal cancer surgery. The meta-analysis which studied the clinical outcomes of 8,000 patients with and without preventive stoma shows that the creation of a protective stoma significantly reduce the risk of postoperative anastomotic leakage. A stoma more than halves the rate of this complication. A protective stoma also significantly reduces the numbers of reoperation related to anastomotic leakage. The number of reoperation in the group of patients with stoma is almost 3 times lower. Despite potential complications associated with the stoma itself and its subsequent closure, the authors conclude that the benefits outweigh the disadvantages. The creation diverting stoma is recommended for patients undergoing low anterior resection for rectal cancer. In another study, the authors tried to investigate how diverting stoma affect the consequences of anastomotic leakage. The results confirmed the assertion about the benefits of a stoma, but negative facts were also identified. Specifically, 20% of patients had complications directly related to the stoma itself, and the mortality rate during stoma closure was 2.4%. Of course, when speaking about the benefits of preventive stoma, one cannot fail to mention the cohort study from Sweden, which was conducted based on the National Cancer Registry. The results, a defunctioning stoma reduced the risk of dangerous complication and short-term mortality after LAR. However, it does not affect long-term survival and oncological outcomes. So, can we speak peacefully? Not quite. A number of studies indicate that preventive stoma can themselves be a source of problem. For example, this meta-analysis from China, which aimed to compare outcomes of patients with ileostomies and colostomies, revealed a fairly high frequency of complication directly related to the stomas themselves. Despite the risk of dehydration and obstruction, the meta-analysis recommends using a loop ileostomy as a preventive stoma in anterior resection for rectal cancer, as it's generally associated with fewer serious surgical complications. It's also important to remember that complications from stoma formation include those that occur after the closure of these stomas, as shown in the study by our colleagues from Belgium. The average mortality rate after stoma closure is about 1%. Furthermore, there is data that may indicate worse long-term functional outcomes in patients with temporary stomas. Thus, over time, we have formed a certain understanding of the pros and cons of preventive stomas, which ultimately led to the question: what if preventive stomas are not needed for all patients with low colorectal anastomosis? Then we ask the following question: so, how can we avoid a preventive stoma without putting the patient at risk? We saw the answer to the question primarily in selecting patients based on their risk level for complications and in careful dynamic monitoring after surgery. But how to select patients? Unfortunately, there are no validated criteria for assessing the risk of anastomotic leakage, although some researchers propose risk scoring scales. For instance, the study from Bulgaria, in addition to various parameters for assessing leakage risk, show which combination of factors more strongly increase the risk of anastomotic leakage. The Greco 17 study plans to use the A4 score. It uses the following indicators: gender, BMI more than 30, smoking status, presence of diabetes, tumor diameter on MRI more than 2.5 centimeters. And in the initial study, they provided the scale scores and how the total score related to the risk of leakage. However, it might be written beautifully and be visually pleasing, but one must read the primary sources and assess how correctly everything was done. Our team reviewed their primary source, and we had quite a few questions and comments. In fact, the main criticism is the lack of validation of their scale. Everyone constantly tries to create various prognostic scores, scales, calculators, but without validation. This is not the first attempt to create prognostic scales. This systematic review presents a number of such publications. Unfortunately, the research was current only until April 1st, 2024. From the tables, only 3 publications seem potentially interesting. These are the CLS and its modified version, and the passage study. After reviewing the CLS and MCLS, our team concluded that the authors approached the creation and modification of the scale thoughtfully, including performing internal validation. The presented results look optimistic. They propose a threshold for the scale of 5.5% leak risk. The sensitivity, accuracy, and area under the curve indicators are good and high. The specificity indicators are not very satisfactory. But for us, this might be less scary, as we would rather be confident in negative results. But these scales still have a drawback. They were created only for left-sided cancers. Is there a clinical difference in leakage between the left and right sides? In the Passage and Calic scale, there is validation, of course, but everything else is done very poorly. It's definitely should not be used and perhaps should not be resorted further either. Together with our colleagues from UFA, we conducted an analysis of data from patients who underwent low-anterior resection of the rectum. The data is presented here together. I think it's more illustrative this way. During the data analysis, it turns out that only a few factors retained any influence. Age, BMI, excuse me. Excuse me. BMI and neoadjuvant treatment. Perhaps our understanding of risk factors and what we know about specific ones is still a debatable topic. Or perhaps the skilled hands of specialists from these centers very effectively neutralize, but we needed this analysis for ourselves and to study our cohort. As a result, we have now made an attempt to create our own scale. We split the sample into two parts, training and test, and using the random forest method, we created our own model. We created a web application using Shiny. You can scan the QR code and try it. We set the threshold and at which the leak risk is considered too high at 10%. But during internal validation, we have so far obtained unsatisfactory sensitivity and specificity indicator for our needs. We plan to collect more data, refine the model, and perform internal validation. This you can see reload study design. All patients are assessed using our scale. Low risk patients for leakage and are randomized in two groups, with stoma and without stoma. High-risk patients who are not included in the randomization will be prospectively will be used prospectively to validate our scale. And we want to assess in the end of study some secondary endpoints like short-term treatment outcomes with 30 days post surgery, rate of reparation both with 30 days after the primary surgery and after discharge. So thank you for your attention and interest to our research. Thank you.
Many things, Emil. Any questions?
Thank you very much, Emil, for this very nice and detailed overview of the data and studies available so far. And I think you showed us a very interesting trial design. When are you going to start this trial? And the second question, is it a unicenter trial only at your hospital? Or you said UFA, or is it a multi-center trial? And how many patients are going to be evaluated?
Thank you for question. I will ask at second question first. We plan to make two centers investigation, our center and UFA Cancer Center, and we plan to collect data from perhaps 600 patients. And can you please repeat the first question, because I don't hear it?
The question is, when are you going to start with your study, or is it already ongoing?
Thank you for question. We plan to start it at 2026, and now we just try understand and validate our scale for risk factors assessment.
Thank you.
Emil,
Very much.
Emil, what criteria for center that would united with you to be how many operations per year in this center should be, or how to check the or randomized quality of surgery? I mean, or maybe what technology should be in this center? I mean, ICG or robotic surgery or laparoscopic, how you manage this?
Thank you for question. We plan to include centers, our center in and UFA center, because in both centers there are some experienced surgeons who made more than 15 lower anterior resection per year, and who can who finish the learning curve in lower anterior resection. And can you repeat the second question?
Second question, the technological criteria for center. I mean, using laparoscopic, open, robotic approach, or some criteria for checking blood circulation, like ICG.
We in our center we have open laparoscopic and robotic surgery, and in the UFA center there is open and laparoscopic surgery. how can we how do we plan to assess centers? It's a difficult question because in the beginning of this study, we plan to do this research just in 2 centers because it will be easier to assess the data, and because we know the surgeons in the UFA center, for example, and we know the quality of surgery because we saw the data from this center, and we know that complications rate in this center is acceptable for this for doing some difficult research in this area.
I see it will be like pilot study.
Yes.
Pilot trial, not
Yes.
for sharing experience for other centers.
Yes, because now we don't know how our risk assessment for patient selection patients will be work, and if results will be poor, I think we should to finish research early. So
many thanks. Any more question?
I have one more question. You showed your design of your scale, how you can measure or predict the anastomotic leakage rate for your individual patient. My question is, when do you say the anastomotic leak rate for this patient is satisfactory? I would like to avoid or do the operation without stoma. And when do you say, oh, you need a stoma? Where is the cutoff for your hospital or for your institution? Is it 10%, 5%? Or when do you recommend to do a stoma?
Thank you for question.
Using your
our cutoff at 10% risk of anastomotic leakage, because more than 10 and more percent of risk of anastomotic leakage seems for us like too high. So 10%.
Thank you very much.
Thank you.
Thank you, Jad. Can you introduce next speaker?
Okay, so can I introduce Professor Jiang? Andrew? So I think the next speaker is Professor Jiang from China. Professor Jiang is the director of GI surgery at Shanghai East Hospital, Tongji University. He graduated in Nanjing University and completed his master and PhD degree in Munich, Germany, and also as a postdoc working 2 or 3 years in National Cancer Institute in Tokyo, Japan. So I think his topic is about the stoma. Would like to give us some information, our Chinese attitude or perspective. So please, Professor Jiang.
Thank you, Professor Chi. Can you hear me?
Yeah, we can hear you. Yeah.
Okay, thank you, Professor Chi, and dear professors. Good afternoon. It's my great honor to introduce my PPT here. Yeah, I hope you can see my PPT slides. Yeah. Okay, thank you. So today my topic is about diverting stoma for low rectal cancer in the new era, current concerns and novel perspectives in China. I have no disclosure. So from annual report of Chinese colorectal cancer surgery database in 2022, colorectal cancer covers around 58% of all colorectal cancers. And in the rectal cancer group, 50% are lower rectal cancer and 38 are middle rectal cancer. But the diverting stoma rate for rectal cancer we have no data, but in our center, for low rectal cancer, around 70% we perform diverting stoma, and for middle rectal cancer, around 20 to 30%, depends on different groups. So in 2022, Chinese experts had conducted a consensus on prosthetic ostomy for middle and low rectal cancer. So that we have definition of prosthetic ostomy and the types of anastomosis, including low anastomosis, that is 2 to 5 centimeter to the denoted line, and ultra low anastomosis less than 2 centimeter is very low. And we defined what is a loop stoma, what is single barrier and double barrier stomas, and we have consensus one of for clinical value of prosthetic ostomy. One is prosthetic ostomy may reduce the incidence of postoperative anastomotic leak, and 2 is prosthetic ostomy may mitigate the severity of abdominal and pelvic infections following anastomotic leak and reduce the rate of secondary surgery. And the 3rd is prosthetic ostomy does not significantly increase surgical difficulty or postoperative hospital stay. And the indications for prosthetic ostomy in China, including the patient factors, the tumor factors, and surgical factors. So we have consensus 4. The individualized risk factor assessment should be conducted for each patient to decide on prosthetic ostomy. Recommended for patients with 2 or more risk factors for ostomy. And we described the surgical technique and the principles, including the stoma type selection, like iliostoma or chronic stoma, and iliostoma is more often used, and the transverse colonic loop stoma is seldom used. And we describe the advantages and the disadvantages of different stoma sites and the surgical principles. And we recommended, I think, for colorectal cancer, priority for end loop iliostoma is recommended, and colostoma is seldom used. And we describe how to prevent and manage the stoma complications, including the early complications within 30 days and late complications. And we describe how to prevent, that is, keep temporary stoma operation simple. The second is avoid correlating stomas on specimen extraction incisions. And we have some more details for to manage the complications. And we have the timing for stoma time is around 3 months, I think, is commonly used also in our center. And pre-preserve examination, we have some examination like MRI, CT, or digital examination, and the techniques. And we have also described so many techniques and indications for preventing stoma, but there are still many problems regarding to the stoma. Ultimate, most around 70% overall rate of complications, and also more than 50% develop at least one complication within 1 year for the stoma, and around 3 to 26% of these ileostomas become permanent. That means that for the patients, and this we describe the stoma problem, including the stoma related, the stomach skin related, systemic related, and it's also closure stoma related, and the quality of life of the patients is not so good for the stoma patients. So the question is there any other solution to avoid not to perform stomas? And many doctors not only in China but also in the world have tried it many solutions, including like ghost ileostomy, like this figure, and also we can use like tube ileostomy, and also we can use transanal decompression tube instead of ileostomy. And also we are familiar with Colovac. There are many trials, or there are many tries to prevent the stomas. So today I would like to introduce the technique. We are now for a clinical trial, that is stent-based intestinal diversion technique, first invited by Professor Cai Xiujun from Zhejiang University. And this is a figure, and I will explain how we perform this kind of stoma using a video. So this is a traditional stoma, the loop stoma, and they have some complications. So we use the stent. So first we just use a stent. First we cut around 20 centimeters from a cecum, from the jejunum and ileum, and we cut an incision. We put the degradable stent inside the ileum, and then close the ileum, and then we put the mushroom-like tube in around 5 to 2 centimeters proximal to this stent, and then the tube was fixed. Is fixed with abdominal wall and drained from the skin of right lower quadrant abdominal wall, and that so that we do not need to perform a stoma. So this is the figure. Finally, we can find out what we do finally, and around 3 to 4 weeks, we put X-ray film, and the stent can degrade itself around 3 to 4 weeks, so that we can take out the mushroom-like tube, so that the patient can go back to the normal life. So usually around 2, 3, 4, or 4 weeks. So Professor Cai his group has conducted a phase 2 clinical trial and published the data. This is the phase 2 clinical trial. This is they're called STT, and this is traditional stoma. And this clinical trial is ICT trial, phase 2 ICT trial. They are randomized 80 patients in 37 for STT and 43 for traditional ileostomy, and they're divided into 2 groups, and they compare the outcome. The outcome found out that for the STT group, the patient has shorter hospital stay. Total stay is shorter, and the costs is also less cost for the STT group because only one operation is needed. And the post-operative complication, no difference between the two groups. But the quality of life of the patients for STT group is better than traditional ileostomy group. So in general, we can find out that the complication incidence for the two groups is no difference. But the patient has shorter hospital stay and lower medical costs, and also better quality of life for from the conclusion of the phase 2 clinical trial. So this is the phase 2 clinical trial. So in last year, Professor Che conducted our national phase 3 clinical trial. That is the safety and efficiency of SDT with ileostomy in rectal cancer patients. This is RCT trial. And we have yes, we have 21 centers for this clinical trial, and the inclusion criteria is for lower rectal cancer. The patient has high risk with anastomotic leakage, and also we perform laparoscopic radical resection of rectal cancer. And this also we have some other exclusion criteria. And the definition of high-risk patients refers to the expert consensus on anastomotic leakage after rectal cancer surgery in China. That is the patient BMI, the patient stage, also new adjuvant radiotherapy, and some other data. So the primary endpoint is the severe complication rate within 19 days after surgery, more than Clarendon 3. And the secondary endpoint includes overall complication rate, the anastomotic leak, the post-operative hospital stay and the total cost, and also the quality of life using SF8 at 9 days after surgery. So the observation period is 19 days after surgery, and the sample size is calculated, and the 285 patients for each group, and totally 570 patients for this clinical trial. And this is the statistical analysis plan, and this is study flow chart. So the randomized into STT group and ileostomy group, and then we perform surgery, and then for observation. This is SOP for our clinical trial, and preoperative period is not different, and the randomized method is stratified broad randomized method. So the post-operative management is similar to our conventional clinical practice, and after 3 or 4 weeks, we performed abdominal X-ray to evaluate the stent degeneration. And the follow-up is 19 days around after the surgery, including vital signs, abdominal examination, and quality of life, and all the data. And this is what we need to do for this clinical trial. So here now, we for this clinical trial, and the study now is on all the patients now is on follow-up, and I think till this end of this year, we will have all the patient follow-up data, and we will calculate and do some statistical analysis to find out whether the difference in the two groups. And in our center, we have 10 cases, 5 the study group and 5 in the control group in our center. And in the data in our center show that no complication over Clarendon 3, and no complication associated with stent in the stent group. And in the control group, that is the ileostomy group, we have the anastomotic leakage that is only chlamydial 2A classification. And we are now waiting for the final results, and we are expecting whether we can avoid ileostomy using this stent technique and to avoid the ileostomy. Thank you so much.
Yeah, thank you very much, Professor Jiang. That gave us a very nice talk, I think. So Professor Jiang used to be my co-workers. We worked in the same department, and a few years ago he found a higher position, so moved to Shanghai. Congratulations. So Dr. Jiang, would you tell us? So I'm very interested in the stent.
Yes.
Created by Professor Tsai, our course Tsai, our classmates, and we also have the same supervisor, Professor Peng, the famous surgeons in China. So a regional idea about this stent is for anastomosis, for the colon
Yes.
or the anastomosis.
Yes.
Because this stent,
you are very familiar with this stent.
Yeah, but not used to be diverting the loops. I think is a good idea. So what is the difference between these two stents? The anastomosis or and I think maybe this is the plaque, just like plaque. Obliterate.
Yes. This is,
and then for sometimes and absorbed, right?
Yes. So for I think Professor Qi, thank you so much for so many years for your direction and for your help for me. And second, I think you are very, very, very familiar with this stent because in the previous design, this technique or this stent is used for to prevent anastomotic leakage for anastomosis. And so this stent, the fecal can pass the stent. But in this clinical trial, we use a stent like just you described. It's like some plaque. The fecal cannot pass this stent. So it's all blocked of the fecal. And then in the proximal ileum, we use like mushroom-like tube to change the fecal. This is the difference between the conventional and the stent we use for clinical trial.
Yeah, so the clinical trials, the data is published or not, or still in progress?
Yes, for first two clinical trials published in Innovation Medicine, and for phase 3 trial, we just finished our patient inclusion, and now we are waiting for the follow-up or data. So I think in till the end of this year, we can finish this clinical trial.
Okay. So what about the other experts? Would you have some comments or some questions? Yeah.
So, President Jiang, a very interesting presentation, and I think it's a really good idea what you do with the stent. My question is, how long do you leave the mushroom tube in, and at the end you deblock it and you can just pull it out of the small bowel and the fistula is closing itself, or how does it work?
Yes, Professor Coleman, thank you very much for your question. Yeah, usually the mushroom tube we pull out around in 1 month. We just play the X-ray film and find out the stent has been degraded itself, and then we take out the mushroom. So the mushroom tube, and so the question is that whether there is some fistula if we take out this mushroom tube. Usually we find out that around 1 month we take out the mushroom, and we did not have the leakage. So all the patient, the whole of the tube can usually cured around 3 to 7 days and cure itself, no leakage.
Thank you very much. Then another question, if I'm allowed to. Do your plug is obstructing the bowel, so you have about 4 weeks without major amount of stool in your low rectal area. Do you check the anastomosis healing during that time or not? Because, after 2 weeks, maybe if you see you have an anastomotic leak, you could work on it, put in an endovac or something like this, to to support healing. Yes. Do you use such measures?
Yes, Professor Coleman, thank you for your question. This is also a very important question. That's whether we check there is leakage or not. So usually the patient can be discharged around after this surgery, and before surgery we need to check using CT scan and using blood test to make sure that there is no leakage for this using this stent. And if there is only minor leakage, and we can just wait in around 1 or 2 weeks to then double check whether the leak can cure itself. And if the patient has some other complications, like if the patient has some ascites or has some fever, or so that for this kind of patient, where in our clinical trial we need to perform ileostomy for this kind of patients.
Yeah, any questions?
I have just technical question. What size of this mesh type tube?
You mean for this mesh tube? Yeah, this
yes,
is
size.
the size is 28.
28 French. Yeah.
28
French. Yes. Yeah.
Rather big.
Yeah.
And the size of stent?
The size of stent is like some kind of plug. So in the inner stent around, I think, around 40, and the outer around 45 or 8, like this. I did not check. I did not check myself, because they just give the stent to me, and it's almost like this way.
Mm-hmm. I see. Any more question?
Can I have a question?
Of course.
Please.
What about feeding of the patient with the plug inside the intestine post-operative during the post-operative period?
Yes, thank you for your question. It's also, I think, important question for this clinical trial or for this stent. Usually during this months, we do not give the patient vegetable. We just give the patient liquid diet and soft diet, and with no vegetable. And sometimes maybe the fecal is a little not so liquid, sense a little solid, and then the fecal maybe can just stamp the mushroom, and then we use some normal saline or just to wash this mushroom, and no problem for the patient.
Thank you.
Thank you.
Many thanks. Okay, many thanks for excellent presentation and interesting technique. I think we don't use in Europe and Russian this technique, but it's rather interesting. And next speaker, we are welcome a colleague from Uzbekistan. In our club, it's first time when colleagues from Uzbekistan share experience, and Dr. Rustamov share own experience about Colovac system. We speak a lot before about system, please.
Good afternoon, dear colleagues. Thank you for your attention. Let me introduce myself. I am a colorectal oncosurgeon from the Akfa Medline University Hospital from Tashkent, Uzbekistan, and I want to show my presentation. Let's start. Our presentation is Colovac 2 device for protection of high-risk colorectal anastomosis. Result our study, SAFE 2023 study. We have disclosures. The SAFE 2023 study was funded by SAFE Heal. The company has that manufactures the Colovac device. No other external funding source were reported. Anastomotic leakage remains one of the most serious complications after low anterior resection, with rates still ranging from 5 to 15%, despite modern techniques. To reduce this risk, most surgeons perform a temporary diverting ileostomy, diverting stool away from the anastomosis. After surgery, patients live with the stoma for several months, usually 2 to 6 months before a second reversal operation is performed. But this protective measure comes at cost. Patients face dehydration, electrolyte imbalance, skin irritation, and even hernias. Living with a stoma affects diet, mobility, and for up to 30% of patients, the temporary stoma is never reversed. So while diverting ostomy prevents leakage-related mortality, it introduces new morbidity and drastically reduces quality of life. The clear unmet need is a safe, temporary, internal method of anastomotic protection. The Colovac solution reimagines this entire pathway. Instead of diverting feces externally, the device provides temporary internal protection. Before explaining the new Colovac 2 system in detail, let's take a quick look at how the technology has evolved over time. The Colovac concept has gone through several generations, each iteration addressing the key limitations of the previous one. It started with the first in-man study, SAFE-1, in France and Belgium, a single stent connected to a manual vacuum bottle. Then came SAFE 2019 and SAFE-2, where a dual stent design and low vacuum alert system were introduced. However, despite good safety results, these early versions still had migration issues, particularly noted in the SAFE-2 trial. The latest generation, SAFE 2023, conducted in Uzbekistan, introduced major design improvements, a dual hourglass stent for stronger anchoring at the intestine, and the SmartVac, a computer-controlled vacuum management device that actively monitors pressure and alerts for leaks or occlusions. These changes were precisely aimed at solving the migration problem while maintaining safety and usability. Here we can see the current Colovac 2 system, the most advanced generation of the device. On the right, the Colovac device itself consists of an hourglass-shaped covered stent that anchors securely to the colonic wall through a continuous 360-degree vacuum seal. Attached to it is a flexible sheath that spans the anastomosis, protecting it from fecal flow during the critical early healing phase. The SmartVac shown on the left side is a self-contained computer-controlled vacuum pump that automatically maintains the correct negative pressure. It alerts the team. It alerts the team in real time if there is a vacuum leak, tubing occlusion, or full fluid reservoir, and can be comfortably worn by the patient or the shoulder or at the hip. Finally, the introducer system shown below allows quick deployment of the device with laparoscopic control with an average placement time of just a few minutes. Together, ColoVac 2 and SmartVac form a fully integrated system for safe, reliable, and minimally invasive internal anastomotic protection. Here you can see our team. The study was type of the study prospective, multi-center, single-arm study, and our objective was evaluate preliminary performance, safety, and usability of ColoVac 2 anastomosis protection device used with together with SmartVac. And there was two sites. First site, Akfa Medline University Hospital in Tashkent, and the second one, Republican Oncological Center of Uzbekistan. The SAFE 2023, as shown on the left, was a prospective investigational trial performed at two sites in Uzbekistan, including 24 patients treated with the ColoVac device between July 2024 and March 2025. Surgeries in both centers were conducted by Dr. Karachun himself as a lead surgeon. In parallel, a larger multi-center SHSOC 23 study was initiated involving 14 sites across the United States and Europe. This trial includes 132 patients overall, with 54 patients in the control arm receiving the standard surgical approach with diverting ostomy. Together, these two trials will provide complementary data, SAFE 2023, confirming device feasibility and safety, and SHSOC 23 delivering comparative evidence versus current clinical practice. The main aim of the SAFE 2023 study was to evaluate the performance and safety of the ColoVac 2 device used with the SmartVac system. The primary performance endpoints include the clinically significant low migration rate, ostomy avoidance, and colon cleanliness before device retrieving, along the usability ratings from both staffs and patients. The primary safety endpoints focused on mucosal appearance at the anchoring site and monitoring for device-related and overall complications. Pre-operative exclusions included patients already in another trial, those with inflammatory bowel conditions, and pregnant or nursing females. Intraoperative exclusions applied to cases with major bleeding, ischemia, positive air leak tests, and or an anastomose located more than 10 centimeters from the anal verge. Overall, these criteria ensured the study focused on a well-defined standards laparoscopic enteroresection patient group. This table summarizes the baseline characteristics of the SAFE 2023 ColoVac group and stoma control group. The mean age in the ColoVac cohort was 56 years, comparable 59 in control group. The BMI was slightly higher in the ColoVac group, around 29 versus 26 in control group. The sex distribution was balanced with 46% females in the ColoVac group. Regarding comorbidities, 20% of ColoVac patients had type 2 diabetes, compared to 14% in standard group. Overall, the two populations were clinically comparable, providing a reliable basis for performance and safety assessment. This table summarizes tumor and surgical details for both the ColoVac and control groups. Most patients had locally advanced disease, T3 or T4 tumors, representing about 64 in the ColoVac group and 67 in the control group. The average tumor distance from the anal verge was slightly higher in colorectal patients, around 9 centimeters versus 6.8 centimeters in control group. In terms of preoperative therapy, nearly half of colorectal patients had received chemotherapy alone, while the control group had a higher proportion receiving combined chemoradiation. All colorectal procedures were laparoscopic with no robotic surgeons, whereas almost half of control cases used a robotic approach. The majority of anastomosis were colorectal end-to-end, consistent with standard low anterior resection. Overall, both groups were comparable, though colorectal patients tended to have a slightly higher anastomosis level and fewer pre-treated tumors. The clinically significant migration rate was only 8%. That's 2 out of 24 patients show a major improvement compared to earlier colorectal versions. Colon clearance at the time of device removal was excellent, achieved in 95% of patients, which was comparable to the standard of care group. Most importantly, 83% of patients avoided a diverting ostomy, meaning that 4 out of 5 patients were able to recover without needing an external stoma. In the control arm, 20% of patients had radiologically confirmed leaks compared to 25% in colorectal group. When divided by symptom states, asymptomatic leaks were seen in about 20% of colorectal patients and 11% of controls, while symptomatic leaks occurred in 12% versus 9% respectively. Importantly, all leaks were detected early by imaging or standard clinical criteria and were managed conservatively without mortality. These findings suggest that leak rates with colorectal are within the expected postoperative range for low anterior resections, indicating an overall comparable safety profile. The overall morbidity rate in the colorectal cohort was 50%, notably lower than 68% in the standard of care arm. Only one device-related event was observed, a minor rectal bleeding episode that resolved within 40 minutes with local hemostasis. Importantly, there were no device-related serious complications and, of course, no stoma-related complications since diversion was avoided. In contrast, the control group showed a 40% stoma-related complications rate and nearly 15% serious stoma complications. We also assessed the usability from both surgeons and patients' perspectives. Insertion was rated as very easy or with only minor difficulty in 96% of cases, with a mean placement time of just over 3 minutes. And all placements were successful. On the patient side, tolerance was excellent. 100% of patients reported being completely or mostly comfortable with both the colovac and vacuum tubes throughout the study period. Device retrieval was also straightforward. 100% successful via endoscopy with an average retrieval time under 10 minutes. These findings demonstrates not only the technical simplicity of the colovac system, but also its excellent patient acceptability, making it a highly user-friendly solution for real-world practice. In conclusion, the SAFE 2023 study demonstrates that the colovac 2 device used with SmartVac is both safe and effective for temporary fecal diversion following low anterior resection. The device showed a low clinical significant migration rate, rate of 8% excellent colon cleanliness, and ostoma avoidance in over 80% of patients without any serious device-related complications. These results confirm that colovac provides a less invasive and patient-friendly alternative to diverting ostomy, reducing morbidity and while maintaining anastomotic protection. However, this was a single-arm, short-term feasibility study with a limited sample size of 24 patients, and longer-term randomized studies will be essential to validate these findings and confirm their reproducibility in broader surgical populations. Overall, SAFE 2023 marks an important step forward in redefining anastomotic protection, a move from external diversion toward internal preservation. Thank you for all. Any questions?
Yeah, thank you very much, Dr. Rustanov. I have several questions or comments. The placement of the device, this is performed by the surgeons during the procedure. My question, in our hands here, if we place an endovac stand or such devices, we have gastroenterologists who do it. Is it easy to handle the device?
Yes. Is it very easy to handle? A device will place it at the finish of the surgery after colorectal anastomosis. After putting of the anastomosis, the surgeon will insert by laparoscopic control. It's very easy from and the tip of the stand will place it higher than sacrum prementorium, 20, 25, 26 centimeters near the splenic flexure.
And the second question is what we sometimes experience with the stents. For protection of anastomosis, or if we have anastomotic leakage, especially also in esophageal anastomosis, we place the stents, and the ends, if the stent is too big and the lumen is too small, you also can get problems, with arterial supply, or get ulcer in the areas of the stent. Did you see any problems? I have seen your is that a problem, or haven't you seen that, or did you check the anastomosis after taking out the stent afterwards, and also the area of the bowel where the stent was sitting?
Yes, the anchoring site, certainly we checked after the retrieving of the stent colonoscopically, before retrieving and after retrieving. Also, we checked these anchoring sites. There was a very small, tiny growth of the epithelial mucosal layer, and after the retrieving, we checked the patients in months. There was no change, any serious problems of the anchoring site.
One more question.
It's very interesting, the device. So I think this is totally the new device. It's not on the market in our country. So I saw from the news, maybe it is preserved by the FDA, and also now it can be used in EU. My question is, what about the price in Uzbekistan? It's expensive or a reasonable price?
Thank you for a question, dear professor. It was a pivotal pilot study, and actually we don't know about prices of the device. it's not on sale now, free sale, but recently this device got the EC certificate in the Europe.
Yeah.
And we know in a few months, we know the price of the device.
Yeah, okay. That's interesting, yeah.
Any more questions? Now we still waiting the next two speakers. That's why we have time to discuss or start discuss the previous talks. Dr. Patankar will be in 5 or 10 minutes.
Maybe I can start. Moritz Schwab from our department, he more gave the clinical insight of our management in Germany. I think also how many centers in Germany try to avoid more and more on an individual basis the creation of a diverting stoma as a basis for our discussion. And I think Emil Churchill, added a nice review on the real data around the world, the problems we have with deep rectal anastomosis, but also on the other hand with stoma. And at the point of decision making during the first step of operation, I think many surgeons do not think of problems created by a diverting stoma and focus on the rectal anastomosis. And I think he really nicely showed this this problems of these both viewpoints. And he also introduced his risk scale. I think that is nice, and I'm going to check out their system about predicting the risk of anastomotic insufficiency. Professor Jiang from Shanghai, in my opinion, he showed also a very nice system using the degradable stand. I actually haven't thought about such a way to prevent stool going over your anastomosis. It's very interesting to avoid a second operation. You don't have a ghost ileostomy or such things. So I think that is a very nice way to avoid a long-term stoma. It's probably also Professor Chi asked the question about pricing. That is getting more and more into the focus in many health systems, that we also need affordable systems for stoma avoidance. And I think this system with a degradable stand and a tube should be affordable for many patients. And coming back to the last speaker, Dr. Rustamanov, showing the Colovac system, I think that is also a very interesting and elegant way to avoid a stoma and to protect deep anastomosis with contact of stool and stool evacuation. So I think in the future we can discuss, is it better to have a little tube on the bowl for some weeks, or you have a catheter or a vac system, a tube getting out of your anus? I think that in future studies we can then discuss what is better for quality of life or handling of the patients. But these two systems, in my opinion, are very nice ways to avoid the stoma.
Many thanks, Professor Korman. Dr. Patankar united with us. Are you ready to start your presentation?
Yes, I'm very much ready. Thank you. Can I share my presentation?
Yes, you can.
Is my audio and video clear to you?
It's perfect.
Great. Thank you very much for your kind invitation to speak on decision-making in colorectal anastomosis. My name is Roy Patankar. I work in Mumbai. These are the two hospitals that I work in. This is my disclosure. Every surgeon carries within him a small cemetery where from time to time he goes to pray, a place of bitterness and regret where he must look for explanations for his failures. What better than this quote by René Lariche to start this talk on rectal anastomosis and the morbidity of rectal leaks? I think the surgeon is often the second victim when you have a leak from a rectal anastomosis. And I'm sure this discerning audience has gone through this gamut of emotions when you have a leak from a rectal anastomosis. I teach my colorectal fellows working with me that a rectal anastomosis is like a marriage. You need to give enough time to your wife, make sure the vascularity is good, and make sure there's no tension in the marriage. If you can avoid these two things, you can be pretty sure that you won't get a leak. So these are the two fundamental hallmarks of making sure you have no problems. We've all been there. The morbidity and the mortality, I think in the best centers of the world, between 2 and 7% of low rectal anastomosis will leak. And the economic and social consequences to the patient are quite significant. There are multiple preoperative risk factors that as surgeons we need to take in account. The serum albumin, immunosuppressed hosts, smokers, BMI more than 30, comorbidities like diabetes, an obstructed bowel, ischemic bowel, and obviously the length of the rectal anastomosis is extremely important. All our patients go through a prehabilitation where we try and optimize nutrition, get them to smoke for at least a week prior to surgery, treat the sepsis before we take them up for surgery. If you look at literature, the predictive factors significantly associated with an anastomotic leak from a LAR is the male gender, chronic liver disease, comorbidities like diabetes, obstructed bowel, emergent anastomosis, and preoperative leukocytosis, and very importantly, an intraoperative blood transfusion correlates with morbidity. So there are many technique choices that we need to make as surgeons when we decide to do a LAR. One is, should we do a stapled anastomosis versus a hand-sewn anastomosis? And generally, the leak rates between the two are common in literature. Realistically, if you have obese male, a narrow pelvis, a low anastomosis, all our anastomoses are stapled. We generally use a triple row stapler in a hospital. And the key technical principles that we teach is tension-free anastomosis, good mobilization of spleen flexure as required, confirm the vascularity is good, careful hemostasis, and avoid distal intraoperative factors that we need to look. Clearly lower the anastomosis closer to the anal leaks. In any case, I will always defunction the patient. We will always do a transanal pelvic TME as a higher chance. And if you have a lot of bleeding on table, a need for a blood transfusion, there is a higher chance of anastomotic leak. We also know that long surgeries with significant more than 3.5 hour time with a blood loss correlates with high incidence of anastomotic leak. The next question that I'm often asked is, should we test our anastomosis intraoperatively? And this is one of my more recent LARs where I'm putting a clamp on the rectum above the anastomosis, and you can see the bubbling coming out. And interestingly, this bubbling was proximal to the anastomosis, by my associate surgeon was holding the sigmoid colon. So there was a small full thickness tear in the sigmoid colon, which we closed with 3-0 Mersilk, and we still didn't defunction this patient. If we did have a bubbling or a leak from a anastomotic line, I would always defunction the patient. But because this was proximal to it, so after this case, I always teach that it's always worthwhile testing your anastomosis intraoperatively. We will also selectively do an intraop endoscopy after the stapling is complete to make sure there is no leak. So you can either do an air or a dye leak. We always do a colonoscopy or an air leak test like I showed you. Sometimes we went through a period when we started doing endoscopy routinely to look for bleeds from anastomotic site or look. And the most important thing to me is look at the blood flow of both sides of the bowel. This comes to our important topic of the day is how to assess the vascularity. I think we are a big fan of using narrow ICG fluorescence or fluorescence guided surgery. We use it from everything in our hospital, from thyroid, parathyroid surgery to lung resection to cholecystectomies, and more recently, we have been using this routinely in rectal anastomosis. I think all of you are aware that ICG can reduce clinically relevant leaks and change your chosen transaction line. And I will show you our own data. This is two videos of how we do it. So proximal, before we engage the stapler, we will give 2 milligrams of ICG intravenously and check the vascularity of the proximal colon and the distal rectum. You see me engaging the stapler after confirming that there is green all the way around. And in this patient, if there is no tension on anastomosis and the vascularity is good, we do not defunction these patients routinely. So this is how we do our anastomosis. In every single patient, we will give 2 milligrams of ICG. We have had in about 3 or 4% of patients had to revise the staple line only because of the ICG showing a little black area in the distal rectal stump. What we've also been doing recently is after firing the stapler, put a telescope through the rectum. And you can see this is a low rectal anastomosis. And ICG is again 2 milligrams of ICG repeated, showing good vascularity of the distal rectal stump. So this confirms unequivocally that the anastomosis is less vascularized. So we can avoid doing a lot of stomas in these patients. The second thing that we use quite routinely is in difficult cases, we put in ICG into the ureter. We were the first group in the world to demonstrate ureteric visualization in 2018. And we have now done this in more than 200 patients. More than rectal cancer, we find it extremely useful in diverticular disease, in colovesical fistulas, colovaginal fistulas, where inflammatory mass often involves one or both ureters. You can see this video on the bottom left, where you can see that there is ICG and the green of the ureter is seen almost up to 4 hours after injecting the ICG. The longest case we have done is a pelvic exenteration where the ureters were beautifully visualized. And this is a patient where I'm doing a redo ventral mesh rectopexy, where you can see the ureters beautifully outlined in this. This is our paper published in Surgical Innovations in 2018. We were the first group in the world to demonstrate this. Our protocol is to put in 50 mils of normal saline with 20 milligrams of ICG into the ureter using a cystoscope. Coming on to the data on ICG, this was a landmark paper by Rees in the British Journal of Surgery, which showed that in 3 to 4% of patients after ICG, the anastomotic line had to be revised. There have been a number of data and published evidence that ICG, although this is not actually come into our guidelines yet, I am convinced there is enough data to make use of ICG a routine gold standard in all rectal anastomosis. Let's now look at the RCTs that have been published. So we have 4 good RCTs, the Essential trial, the White trial, the Intact trial, and the ICG colorectal trial, all of which show that the incidence of anastomotic leaks decreased statistically by using ICG in rectal anastomosis. The data in right colonic anastomosis is mixed, but in rectal anastomosis, I have no doubt in my mind that ICG fluorescence is now soon going to become the standard of care. Not very popular in many areas of Europe and the US, but in India, we are quite bullish on this. And we are in the process of publishing our own data on left colonic and rectal anastomosis. This is a compiled slide looking at 9 RCTs, looking at almost 5,000 patients, where you can see there is a significant improvement in patients with ICG. What is going to be the future? We are working with a camera manufacturer looking at the implementation of artificial intelligence, which should tell us the anastomotic line and the degree of vascularity. This is a paper published in JAMA of 2020, looking at the use of ICG to do what is called color-coded surgery. The newer cameras that we have are no longer just green and gray. We have what is called the color segmented fluorescence, and depending on the amount of vascularity, you will see red, yellow, or blue, indicating to us the degree of vascularity of the anastomosis. I think an important factor bothering the quality of life of a patient is a diverting stoma. We will now, I think if you ask me this question about 7 years ago, virtually all low anterior resections had an ileostomy done in our unit. We are a high volume GI unit, and over the last 7 years, even in patients who have preoperative chemoradiation, if we find that we have no tension and good vascularity, we have started doing ileostomies only selectively. We do know that covering stomas do not prevent leakage, but decrease the morbidity and the consequence of the anastomotic leak. There are many meta-analyses with this, but I will keep my decision short. This is the algorithm that we follow in our hospital. A preoperative assessment, an intra-op check. If there is a low-risk patient, we will do a primary anastomosis. If the vascularity and tension is not an issue, we will not do a stoma. Intermediate risk, we will do a ICG and do a selective stoma, but in high-risk patients who are grade 3, grade 4 ASA, or where the anastomosis is within 5 centimeters of the anal verge, we will do ileostomies in all patients. So this is just to give you a brief overline of what our protocol in our unit is. We have now started using ICG fluorescence in every single colonic and rectal anastomosis, and in about between 3 and 4% of patients, we will revise anastomosis, or a decision to do a stoma will change purely because of ICG fluorescence. The takeaway, ladies and gentlemen, is perfusion before precision. We will do ICG guided assessment. We always visualize the ureter in difficult cases. So in all inflammatory bowel masses, diverticular abscesses, colovesical fistulas, colouterine fistulas, we selectively outline the ureters. To a surgeon, tension is the enemy. Divert selectively, not routinely. Recognize and rescue early. Drains do not help in picking up leaks. Intra-op, I showed you our own video of intra-op testing showing this. And finally, it is sound surgical judgment that will save the patient's life. Thank you very much, ladies and gentlemen.
Many thanks, Dr. Patankar. Any questions from floor?
Thank you very much for your interesting and very practical presentation. I have a question about the intraoperative endoscopy. Do you do it yourself, or do you have an endoscope, or do people from gastroenterology come and check it for you?
So-
Because it's
So in our country, all my fellows, all colorectal surgeons and fellows will do their own intraop colonoscopies. It's very difficult logistically to coordinate with a gastroenterologist to come into theater just when you need them.
Yeah. So do you have equipment in your OR that you have the endoscope? You need that.
So in our hospital, all ORs have an endoscopy unit of their own. And whether we're doing a LAR or otherwise, we have a colonoscope at our disposal.
Okay.
No comment. The Zheng Hospital is very famous in India, in Bombay.
Dr. Patankar, second question about rectoscopy. You showed ICG checking during rectoscopy. Do you use laparoscope for rectoscopy in these cases?
So we keep a separate laparoscope that goes transanally to see the distal rectal stump. So one laparoscope trans through the umbilicus and one from below after firing the stapler.
It's very interesting thing because the common colonoscope doesn't have this ICG function.
So the colonoscopy is only to look at the level of anastomosis. If we have a worry about the margin, then we will tattoo or put a clip on the growth. But to check the vascularity, it's always a laparoscope using ICG.
I think this is also very, very interesting technique. So you on a standard basis, you have a second laparoscope ready in your OR to check the ICG, as Andre said. Yeah.
Yes, we have a separate tower kept only for this.
Okay. And may I ask, you showed the visualization of a ureters by ICG. So as when I understand, I haven't read your publication you cited, but you go in the bladder and then intubate the ureter ostium and inject ICG solution. Did I get it right?
Yes, Dr. Marco, we will do a cystoscopy. My urology colleague will do that. Put in a cystoscope, put in a ureteric catheter about 5 centimeters above the uretrovesical junction, inject 50 mils of normal saline with 20 milligrams of ICG, and the whole ureter is seen glowing green or gray depending on your mode for up to 4 or 5 hours after injection. It stains the urothelium. And I think more than rectal cancer, it's a big advantage in diverticulitis when you have an inflammatory mass and the ureter may be pulled into the mass. So we've been doing it for the last 7 years, and you have a pretty large series with this now.
Very much, very nice technique.
Thank you.
Yeah, can I ask you in China we also have such the technique by ICG, especially in some university hospitals, no problem because it's very well equipped. How about the small hospital or even the county hospital? Is very popular this technique in India or not? Or just only concentrated in your hospital, because your hospital is famous. I know Zheng Hospital is very famous in Bombay,
Thank you. Thank you for saying that. But we are a private hospital, but a teaching hospital. The use of ICG is fairly selective. The larger high volume colorectal units would be using it routinely, but the peripheral hospitals may not have access to ICG.
Okay, thank you.
We can go to conclusion if nobody has a question. Professor Yunli with us or no?
I don't have more to say. That I think this is a very good, the meeting, web meetings, because the people from the different places with our different accent, but the idea is very important. So we share our ideas, they share our experience, and this time this is so many new. The technique that is interesting. So thank you very much, Dr. Andrew. So you have did a very good job. Okay, thank you.
Many thanks. And it seems to me the very important statement that Dr. Patankar start from Lerish, that we have our cemetery, unfortunately, and the second victim of leakage is surgeon. And of course, the idea of this seminar grown from we are not satisfied one side from complication of diverting stoma, that we have high rate, and as show all speakers, and we still have high rate of leakage. And of course, different system, Colovac or mushroom tube and so on, can't change clinical practice, that we should very, very precise to check this patient every day, the temperature, the blood test, the it's need colonoscopy, that do not lost moment when we should redo operation or protect patient. Many thanks all speakers for very informative and interesting webinar. And Marco, maybe close.
Yeah, I summarized the talks before. In addition, I think in the last talk we clearly heard that the focus also has to be to really avoid complications in the first operation, to check the anastomosis. I think also ICG is very important. And what I think also, what you also showed in your talk, that the inspection of the anastomosis by endoscopy directly during the operation is probably a good tool to make sure and that you have an intact anastomosis, good-looking anastomosis that really can help you to avoid diverting stoma and to support surgeon to go this way. And here, for example, in Germany, we do not routinely do it and check it directly after the operation, but in my opinion, we should really think about it. That's also a lesson I have learned. I think it also very interesting that you have two endoscopes and check the anastomosis after construction intraluminally by a second laparoscope. That's also very nice technique. So in summary, I think we had a good meeting, gave an overview what is internationally ongoing. I found it very interesting for me. We do not have these systems in Germany. To hear about the degradable stand, about the Colovac system. So I think it helps us to improve the outcome of patients with rectal cancer, avoiding stoma, increased quality of life. And so thanks to all speakers. And finally, I would mostly thank Andrei Ivanov, the secretary of ICRCC, who is always in charge of organizing the Zoom meetings with his staff in St. Petersburg. Thank you very much. For making it possible that we can launch such international Zoom meetings. And of course, also the co-chairs, Professor Chi and Professor Lu from China, who help us to continue these meetings within the group of the International Colorectal Cancer Club. And I see Carl Link, one of the founders of the International Colorectal Cancer Club, several decades ago in Wiesbaden. Maybe you can give us some words.
Switch on your microphone.
Hello to everybody. Interesting talks. Thank you. In my next life, I will use endoscope to control my quality. Good proceedings. Thank you.
Yeah. Okay. So again, Thank you very much to all speakers. I don't know, Andrei, do you want to finish the today's Zoom meeting with some words from the secretary and the organizer?
Good. In China, it's good night. It's 7 o'clock. Yeah, nice to meet you, Professor Link. Yes, nice. Yes, very nice, this meeting. Thank you. Ivanov did a good job. Because I'm in Peking, a conference, so I'm not convenient to speak more. Thank you very much. Thank you very much.
Actually, from the point of the president of the ICRCC, I would really, animate and push people, also our speakers today, from Uzbekistan, India. If you have interesting topics, please forward them to Andrei Ivanov, and then we organize the next meeting, probably beginning of next year, because I think it's very good on this basis to discuss, get new ideas, improve, the quality of treatment of our patients with colon and rectal cancer and other colonic diseases around the world. So, please give this on to your co-workers. If there are interesting questions or topics, forward them to Andrei Ivanov so we can organize a next meeting about it.
Yes, of course. I'll completely collect idea and we discuss next topic. Many thanks.
Thank you very much to all. Have a nice weekend or evening and night in China. Goodbye.
Goodbye.
Bye.
Bye.